And dear colleagues, it's been a pleasure, and I would like to thank you for the invitation. In this 30 minutes, we'll go over the recent advances and how we can approach difficult clinical scenarios. So I can give you heads-up information. I want to ask you, does anyone know the #1 country in the world doing most MR examinations per 1,000 patients? Yes? Yes. According to OECD numbers, it's amazing, but we're doing the most MR examinations for our patients. And in our hospital, we're doing almost more than 70,000 MRIs per year. We have 5 MRIs and 7 CT scanners. So we're doing a lot. The reason for that, I've been going all around the world and giving lectures on liver imaging. The reason is very simple, it's very cheap. We're doing MR examinations per 20 to 30 euro. So, and as you can see, the contrast agent for MRI is also free, and it's supplied by the Turkish government. So, finally, we can start. I think the most important thing that you would understand from this lecture, excuse me, ön ışıkları karartabilir miyiz? This image is an MRCP image, and I'm going to focus the talk on MRI and MRCP. And this is usually what you get from ERCP. But the thing is, we're doing much better than this image because we can do thin images. You can see that there was a stricture at that point, and you can see that the stricture is actually a short stricture. And moreover, we can do cross-sectional imaging in addition to these ERCP-like images. And if I zoom up the image, you can see that the wall of the common bile duct is involved. So this is the kind of detail that we can obtain routinely in our practice. So I'll briefly talk about the technique, which is important. I'm going to briefly mention how we characterize lesions within the biliary system. And also, according to the level of obstruction, it's important to have this differential diagnosis. And then we're going to look at the extremely diagnosable cases and how we use imaging for decision making. So I know most of the time surgeons and gastroenterologists are confused with MRI imaging, but MRCP has a very simple principle. We image the water in the body. So we blacken every other tissue, but we see the water. Therefore, sometimes you can see the biliary system, but in addition to that, we can see the fluid in the stomach, the duodenum. You can see the fluid within the renal collecting system. And also, does anyone know the structure going in the midline? This is ductus thoracicus. So we can even see the lymphatic fluids within the lymphatics. So what we learned from our practice, and this is a real problem because most of the MRIs or MRCPs from outside institution, they have only MRCP images. It is not enough for complex patients. And we learned that in addition to these MRCP images, you need to give contrast and you need to obtain axial and coronal images. And we always use hepatocyte-specific contrast agents. The importance of these contrast agents is that when you give the contrast agent, you can see the portal vein, hepatic artery, the venous system. In addition to that, we can see the biliary system. So it's excreted within the biliary system. And multi-hands is one of them, but currently it's not available in the country. But Primovist, although it's expensive, it's free in Turkey, so we can use for all of our patients. So the basic thing about MR techniques is that with ultrasound and CT, you can think that if you look at this image, one thing, right? You see the circles. But actually, if you look from a different point of view, these are not circles. So that's what MRI adds us in routine clinical practice, to have a different point of view so that we can understand things better. And how we do this? We can obtain coronal or axial slices, which is very helpful to us. We can obtain 2D images, two-dimensional images. And these are only 1 second images, so it's very quick. And also recently we've been doing 3-dimensional imaging, so we can look at the image from every point or any angle, and this usually takes 2 to 3 minutes. So what is the advantage of 3D imaging? It's really amazing because we can see things better. I want to show you that on an ERCP-like image, it's difficult to understand the relation between the cystic duct, common bile duct, and the aberrant right posterior duct. But if you look at the three-dimensional images, what we call volume-rendered images, you can see the cystic duct is located between the common hepatic duct and the right posterior aberrant ductus. And we know that this is very important for surgeons. And another thing you would hear a lot is diffusion-weighted imaging. We use it in all our patients. And don't be confused again with diffusion imaging. I told you that MRCP is a water imaging. Diffusion is another water imaging. This time, we're measuring the movement of the water in cubic millimeters. So this is almost a microscopic imaging. So biliary system, what does it add to us? I want to show you a normal common bile duct. You can see that it disappears with the diffusion-weighted imaging. But if you look at the tumor, it's getting brighter. So it really helps us to see, most of the time, the biliary tumors are difficult to see tumors, so we can see with diffusion-weighted imaging, a kind of microscopic imaging, and this takes only 20 seconds in our routine protocol. Okay, how about functional MRCP? Functional MRCP, we described this actually back in 2009 in patients with cholecystitis without gallstones. How you can use this technique? We know that from nuclear scintigraphy techniques, if you use the high-dose scintigraphy, you see excretion into the common bile duct, but there is no entrance of that material within the gallbladder. So we use the same principle with the hepatocyte-specific agents, and when you give those contrast agents, you can see that it's excreted into the common bile duct, but there is no entrance of contrast medium into the gallbladder. So we showed that actually this is very useful for diagnosing cholecystitis without gallstones. So to make it simple, MRCP is not just a luminography. So we don't just see the lumen, but we can look at the wall of the biliary system. We can see the adjacent structures, and we can see if there's a stone or a mass, and also we can diagnose air within the biliary system. And also, the most important thing is we can see things that cannot be shown on ERCP. So a very nice example of a stone within the biliary system, and also we can differentiate stone from the air. And you can see that this is a hydatid cyst entering the common bile duct. And here you can see that there's a tumor involving the proximal common bile duct. And also, if you look at this patient, we were very concerned about this thickening. It was almost measuring more than 5 millimeters, and we thought that this could be a malignancy. The first brush biopsy was negative, so we told them to do another brush biopsy, which was positive. So how can we see obstructive system? I want to show you this post-operative patient who had cholecystectomy. So the patient presented with pain and fever. ERCP was almost normal, but they couldn't show the right posterior duct branch. And when we did the MRCP, you can see that the common bile duct looks almost normal, but look at this ductal system. This is the right posterior duct draining the segment 6, and you can see that there is obstruction at this level. That's why you're not able to see this on ERCP. And if you look at the axial images, actually there is an abscess at that location. So we can also use these hepatocyte-specific agents, which is called Primovis, and you can see that there is no functioning liver tissue at this area. Okay, another very important thing that we just don't look to the biliary system, but we can see the adjacent liver, the vascular system. If there are any lymph nodes, we can see the pancreatic duct, which can be helpful for differential diagnosis. And also we can see any other organ within the upper abdomen. So hepatic artery compression is a very important pitfall for MRCP because it can look like stricture, but it is not. This is due to the pulsation effect of the hepatic artery. So we can really show that because on other images, you can see the tiny hepatic artery crossing the common bile duct. So it's very easy for us. And also, I want to show you these three different patients with the same etiology. And it's a very important clinical diagnosis because if you don't think that there is this pathology, and if you try to biopsy, the patient might die because of biopsy. So what is this? It is called portal biliopathy. This is due to chronic portal vein thrombosis, and the level of obstruction is really different in different patient groups. So in this patient, the obstruction was at two different levels because this time it was caused by the dilated hepatic artery. And in this patient, it's at the level of phylum. You can see these blood vessels, and sometimes really it can mimic a mass because they're so vascular and look like a mass, but you have to be careful if the patient has a chronic portal vein thrombosis history. And you can see the compression at different points, and these are usually due to these blood vessels. So we always use diffusion in these patients because diffusion, there is no restriction because there is flow within these structures, so it really helps us to avoid biopsy in these patients. And also another thing, if you look at this MRCP, you can see that there is obstruction. What is the reason for this? Is there a stone? This time there is nothing within the biliary system, but you can see there are big lymph nodes compressing the common bile duct, which is important for treatment purposes. And also, what is the importance of pancreatic duct? So seeing the pancreatic duct without injecting any contrast into the pancreatic duct helps us to differentiate between a metastasis or a primary tumor. Because if it is a primary tumor, you can see the level of obstruction in the common bile duct and the pancreatic duct is at the same level. But if you have this kind of appearance, you can see that the mid-common bile duct is involved and also the pancreatic duct at the level of pancreatic head. So the levels are not the same. This was a metastasis from stomach cancer causing jaundice. And also, sclerosing cholangitis is an easy task for us because the imaging criteria are very useful. But I want to let you know about this new or more frequently seen disease. Probably we have better tools to diagnose this. This is called immunoglobulin G4 associated disease. And in the last 5 years, we learned that it is a multi-systemic disorder. So it doesn't just involve the pancreas and common bile duct, but it can involve the heart, it can involve the aorta, and also you can see lesions within the kidney. So whenever we see a mass-like lesion within the pancreas or the common bile duct, we always look at these organs because there's a very useful thing for us, and it doesn't matter if it involves the common bile duct or the pancreatic duct. It doesn't cause full obstruction. It doesn't cause complete obliteration of the lumen. You can see that there is mild dilatation of the Wirsung distally, but if you can see the lumen of the pancreatic duct at the body of the pancreas. So this is a very useful sign for us to diagnose this benign etiology, because if you try to biopsy these patients, it's difficult, and all you need to do is to look at the immunoglobulin G4 levels. So if it's elevated, you need to supply the patient with steroids, and they have amazing improvement in the clinical and also in the radiological findings. And also in pregnancy, we use a lot of MRCP. I want to show you two different patients from our hospital. You can see that in this patient, the common bile duct is dilated, but there is no stones. So this is usually pregnancy-associated cholestasis, and you can see the head of the fetus actually at that level. But this patient was not that lucky. This was a type 1 colorectal cyst diagnosed during pregnancy, and the patient underwent hepaticojejunostomy in the 3rd trimester after this MRCP. And also sometimes a normal liver can look like a tumor, and this is a very nice example. This was referred to us as a mass within the liver but we know that this is very typical for an end-stage primary sclerosing cholangitis, and this is known as pseudotumor appearance. So it's an end-stage disease, and you shouldn't call this a tumor, because if you remove this part of the liver, the patient would die, because this is the only normal part of the liver in these patients. And it is due to caudate hypertrophy. I want to show you a very interesting patient. So it was a 2005 image. You can see that there is obstruction. We thought that the patient had Klatskin tumor. But when we did the brush biopsy, they were all negative. So our surgeons decided to do surgery to this patient after bilateral biliary drainage. And if you look at the axial images, really we don't see the tumor here. And the biopsy after the surgery in this patient was inflammatory pseudotumor. But there was so much fibrosis within this area at the hepatic hilum, they couldn't do hepatic angiogenestomy. And believe it or not, we've been following this patient with bilateral catheters since 2005, and she's doing really good apart from these external drainage catheters. Okay, so what should we think in the patients with proximal, mid, or distal strictures within the biliary system? This part is usually, you don't see much in your clinical practice because these are oncology patients most of the time. These are chronic patients, and this is a pathology involving the lungs and the liver. It's known as Langerhans cell histiocytosis. So the lung findings are typical, so if you see it and a biliary stricture associated with that, you can easily understand what's going on within this patient. And also, we're seeing more and more cases of hepatolithiasis in patients, and these usually can be treated by percutaneous techniques. And also colon cancer is very important. So this is a very important finding in patients with colon cancer. So if you see a biliary dilatation, and if you don't see a mass on CT or on regular MRI techniques, you should keep in mind that there should be a metastasis, because colon cancer can cause biliary dilatation. And you can see the tumor on the diffusion-weighted imaging, which was not visible on other imaging methods. So these are 3 different patients with proximal stricture, and in all of the patients, the diagnosis is different. In this patient, it looks like a Klatskin tumor, and we proved that actually there's a big tumor, which was a Klatskin tumor in this patient. How about this one? It looks like a Klatskin tumor, but this is another type of cholangiocellular carcinoma. This time it's an intrahepatic cholangiocellular carcinoma causing an biliary dilatation and so extending to the hilum. How about this one? Again, this looks like a Klatskin tumor, but it is not. It is a difficult diagnosis, and MRI is very helpful. You can see the liver. This patient has a history of hepatitis B, and if you look at the liver, it's totally abnormal. And I want to show you, you all know these findings, many hypervascular lesions within the liver, and all of them show washout. And also, the left portal vein is occluded with tumor, so this is a very nice case of diffuse hepatocellular carcinoma involving the whole liver, and it's causing also biliary obstruction. So I want to show you this patient, which was an intrahepatic cholangiocellular carcinoma. So our residents were concerned about this, if this was a mass or not, but this was not a mass. It was a focal fat, and due to changing of perfusional and biliary drainage pattern. And this was a very educational patient to us, because if you look at the CT images, you can definitely see at the level of Klatskin point, there is a tumor. And we read this as a Klatskin tumor. But we forgot to look at the hospital information system, because the patient had sarcoidosis. And this was the MRCP, and everything resolved after the treatment in this patient without any surgery or intervention, because this was due to sarcoidosis. So just remember that this benign disease can look like a malignant disease. How about if you see a mid-stricture in the common bile duct in these 3 different patients? So the first one is actually a primary tumor. You can see the tumor right there causing obstruction. How about this one? it looks like a stone, but you prove the stone with the thin images. And the last one was a very interesting patient because this patient had a breast cancer, and believe it or not, there was a metastasis at that point. So breast cancer is a crazy disease. Does anyone have a diagnosis in this patient, Dr. Hanna? No? Perfect. It's a MERCP syndrome. ERCP is a defective technique in these patients with MERCP syndrome. And the reason is you just inject the contrast and it looks like a tumor, but it's not a tumor because it's a stone located in the infundibulum of the gallbladder. And this was a difficult diagnosis because in this patient, you can see the stricture, but it is due to a very small stone at the hilum, and there was associated inflammation causing problem in this patient. Okay, so pancreatico-biliary junction was a difficult area for us, but with recent techniques, I want to show you this image. You can see that the common bile duct and the pancreatic duct on these high-resolution images. So it's really helping us in our routine imaging. So my question to you, we have 4 different patients. Which one you think are malignant? So can I see the hands? Who thinks patient 1 is a malignant patient? Patient 2? Perfect. Patient 3? Patient 4? Perfect. So really, only the second one is a benign disease. So this is what is tricky about MRCP. If you rely on these images, you're always wrong. So the first one was actually a borderline disease. It was a carcinoma in situ, right there. The second one was a stone which was not visible on the 3D clearly, but if you look at the thin images, you can see the stone right there. The third one is actually, this was another benign one, I forgot to tell you, because the reason for this was, you see the structure, pancreatic duct, common bile duct, this is diverticulum. So juxtaduodenal diverticulum or para-sphincteric diverticulum looks like this, and it can cause sometimes obstruction. And this one was a periampullary tumor. And you can see axial image, a big tumor causing this double duct sign in this patient. Okay, in this patient, you can see the stricture. The stricture, we always look at the contrast enhanced images, and you can see the tumor clearly in the distal common bile duct. Sometimes it's really difficult for us to see these very small stones, like in these patients, which is located at the very distal part of common bile duct. Okay, I want to show you, I know that the last lecture would be about colorectal cyst. I want to show you how we see it on MRCP. This is a very typical type 1 colorectal cyst. Type 2 is known as a diverticulum from the common bile duct. Type 3 is located at the level of papilla. You can see the strict dilatation. And type 4 is a combination of intrahepatic plus colorectal cyst. And type 5 is known as Carolus disease. And the findings on imaging is very typical. So if you look at this disease, actually, this is a spectrum of disease. And we learned that, actually, if it involves the distal part, it's known as von Meyenberg complex. It involves the mid part of the common bile duct. It's known as adult polycystic liver disease. And if it involves the big system, it's either known as Carolus disease or colorectal cyst. And altogether, these are known as ductal plate malformations. And this is a very nice article that you can see. And also in the clinical practice, the most common problem that we see is, if you see an hepatic cyst, you want to learn that if it is associated with biliary system or not. And you can see that we can actually prove it by using this Primovist or hepatocyte-specific contrast agent, because it looks like a cyst, but if you give the contrast, you can see accumulation of the contrast within the cystic structure, proving that this is a cyst with a biliary communication, and it's very pivotal in treatment and management. And also, this was a recent observation that we published. It was really difficult for us to see the reflux from the biliary system into the pancreatic duct, but this was an incidental finding in our practice. We saw that the contrast was excreted into the biliary system, and you can see the reflux into the pancreatic duct. And actually, this was never being shown by imaging, so this was the first patient that has been shown with this contrast agent. Okay, how about rare but diagnosable cases? I want to show you this patient because this is a mimicker of Carolus disease. You can see many dilated biliary system, and the disease is also known as hereditary hemorrhagic telangiectasia. And the reason for this appearance is the biliary ischemia, because it's supplied by the hepatic artery in these patients. And this was a patient from my fellowship in the United States, and you can see that the imaging findings are very typical, and the patient underwent transplantation in 2 days, and she did well after the transplantation, because liver involvement in these patients has a dismal prognosis. And this is the article describing these. How about this one? We recently published this article. Our surgeons were concerned about this mass involving the left and the main ductal system, and you can see there is also right-sided dilatation, so they were concerned if they can resect this, and we told them actually this is an intraductal biliary tumor, and when we gave the patient Primovist, you can see actually even though the system, the right system is dilated, it's functioning, and the contrast is going into the common bile duct. So our surgeons were able to do hepatococcygestomy, and the patient has been living for the last 4 years. So the patient was treated based on imaging findings. And also I want to show you these two very interesting patients. This patient has a biliary ectasia and also a similar appearance in this patient. So how we can differentiate between these two entities? The diagnostic clue is the injection of the Primovist, because in this patient you can see that the contrast is flowing within the biliary system, the ectatic one, but look at this one. There is no excretion into the system. So this was another form of intraductal tumor within the biliary system. So we're seeing more and more patients actually. These are very similar to IPMTs within the pancreas. And this was a puzzling patient to us. You can see it looks like a tumor, but when we look at the axial images, the patient was not septic actually, but the patient had right upper quadrant pain, and we didn't know really what was going on with this patient. There was a cystic structure, and the patient came 1 day later. We called back the patient after imaging, and the next day appearance was this one. Does anyone have a diagnosis? Actually, believe it or not, when we go back, this was a perforated, closed perforation of the gallbladder, and the patient did the self-treatment because it fistulized to duodenum. So the gallbladder was perforated, and then it fistulized into the duodenum. Okay, so if you see this kind of appearance after cholecystectomy, Dr. Hala, what would you think? It looks like the whole system is obstructed, right? But it is not, because it's only the segments 6 and 7. So I've shown this picture earlier, an aberrant duct. So if you clip the cystic duct and the aberrant duct, this is the result. You can see the obstruction of the segment 6 and segment 7 ducts. So the most important thing that we learn in the area of biliary imaging, do not just look at the ERCP-like images, but look at the function of the liver. So I want to show you this patient. This looks like there are many strictures in the biliary system. This was a patient with primary sclerosing cholangitis, but when you injected Primovist, actually most of these ducts are functioning even though they're dilated or strictured, because these are the areas of atrophy, but the rest of the liver is doing quite good actually. And also in this patient with a complex tumor in the Klatskin area, we can show that there are many areas of involvement, and also the left portal vein is occluded. So we obtain whatever information we can obtain in these patients by giving contrast. And also in colon cancer patients, we try to do our management based on MR findings, because this patient might benefit from biliary drainage, but look at this patient, left-sided, dilated, but the whole left lobe is involved. So even though if you do biliary drainage to this patient, it wouldn't be useful because there is no normal parenchyma at that level. And also we can use it in hepatic angiogenestomy, and we can show malignant tumors or recurrence in these patients or benign strictures at this level. And really, technology is very available to us. You can see different liver segments. We can calculate the volumes and also the function. So this is a recent article that we published, and you can see in addition to these images, you can show dysfunctioning or atrophic liver with Primovis. So this is the end of my talk, and I want to emphasize that really we can see much better than other techniques for biliary imaging. Thank you for your attention.